So what I wanted to do was provide a very brief introduction to Cascades, and then also to the Sustainable OR scorecard, which I think has strengths and a particular value and can be an input into the further work of this group. So this brings us to the Sustainable Operating Rooms work that we've done, which actually predates Cascades, and Cascades has been able to leverage and started is something that my center has supported. And it's come about through, I feel like cut my teeth on how to collaborate and work with partners in the health sector through this community of practice in particular, which is a collaboration between the 14 academic hospital corporations affiliated with the University of Toronto. It's called TASN. Many of you will be familiar with it. And the University of Toronto Council of Health Sciences. So that's 7 health science faculties at U of T, a collaboration for high quality, low carbon care. We've just finished our first term of 2 years and have a refresh and a commitment to a second term of 3 years to continue and deepen this work. And operating rooms was an obvious place to do work. And we had already been doing work previously through the Department of Surgery's Best Practice in Surgery team. So gave us a great opportunity to do more. So I just want to, obviously this is work that, as I say, I and my team don't bring the expertise to this. We bring some coordinating capacity. And so the working group of experts here, Dr. Robin McLeod, many of you will be familiar with her, an officer of the Order of Canada who's led this work, Ali Abbas, anesthesiologist, Laura Donahoe, a surgeon, Emily Bairstow from the Best Practice team, and Ed Rubenstein, more than 20 years of work supporting environmental sustainability in hospitals. And then the workhorse team over here of Cameron Orani, an OR nurse who's been central to this work, Sabrina Santos, who finished her thesis from the Masters of Sustainability Management on this, Adana, medical student, a couple of members of my team, Naba Khan, who's here, a fabulous designer, and I've provided some support to this as well. So what is it? We did make a new scorecard. It drew on the rapid review and guideline development process from our work with best practice in surgery, and very much was informed by discussions with expert stakeholders across TASN. And in some ways, it clearly reflects the kinds of things you would always measure, the key areas of environmental impact. And this is a great image. Thanks, Naba, for this. This is an image of the perioperative care or surgical suite, I suppose, in terms of where the greenhouse gas emissions are coming from. And it puts it in the language of the greenhouse gas protocol, which is a slightly cumbersome but still useful way of talking about greenhouse gases, where they occur and who has responsibility for them. And so what we typically talk about in terms of greenhouse gases and an organizational's accountability is that they have direct control over some emissions. That's scope 1. Typically, that's going to be their boiler. For anesthesia or the operating room, it's actually inhalational anesthetics, because we know that the volatiles, desflurane in particular, are very, very high global warming potential. Desflurane is 40 to 50 times higher global warming potential than its clinical equivalent of sevoflurane. And then there are other halogenated gases, and then there's nitrous oxide. And these are estimated to be about 5% of acute hospital emissions and up to 50% of the perioperative care's emissions, certainly in high-income countries that can afford DES, basically. If you can't afford desflurane, and lots of countries haven't used it, then your impact is lower. But there's obvious opportunities with those directly controlled emissions. And then the other category folks talk about is scope 2. And that's really these emissions that healthcare organizations don't create on site or through their owned and controlled buildings or vehicles, but that they are very easily measured because there are other folks making energy for them. So here for the operating room, we're talking about all of the energy that goes into HVAC systems and lighting systems. And then scope 3, that's where the bulk typically of healthcare's climate emissions exist in the operating room. As I say, we've got this extraordinary opportunity around the directly controlled inhalational anesthetics. But scope 3 is typically much harder to measure. And this resides in reusable products or the potential for reusable or extended use. It's our supplies, and it's in waste to some extent. So here, reusable gowns we looked at, extended use, disposable anesthesia, extended use of anesthesia breathing circuits, reposable laryngeal mask airways, and then for reducing waste, specialized custom packs, and segregating biohazardous waste, trying to avoid too much of the too much non-biohazardous material going into the biohazardous waste stream, which then is both an expensive and highly polluting disposal process in terms of incineration. So those are the areas. So as I say, what we have in our scorecard aligns with what we know. This is from Andrea McNeil's piece, looking at emissions in the surgical suite. But then what do we do? And I guess what I want to stress in this conversation is that we need to design these exercises for the communities we're working with, and that's how they have their most leverage, in my opinion. So really our scorecard was designed within the context of a benchmarking exercise. And it was really designed for the visibility to CEOs. And Andy Smith, Dr. Andy Smith, the CEO of Sunnybrook, was a really strong supporter and kept reminding me to try to be less of an academic in the work that we were doing, to try and make it practical and usable for people with limited bandwidth to get the story. So it's 10 items. Why 10 items? For CEOs. And it's a simple traffic light heuristic. I think it's still super useful, but I'm trying to explain, how do we get these things done? So where red is not happening, amber is in process, and green is achievable, ambitious, but feasible. So for example, we ended up with desflurane off formulary as our green score for that particular category of activity, but it didn't become our green score until the first hospital fell, until the first hospital took it off formulary. And then there was quite a bit of, or a fair bit of backroom conversations that had to happen to make sure that by putting that out as the green score, we weren't going to actually create resentment, or, because there's absolutely no value in that. So it had to be ambitious, but feasible, respectful of the community that you're working with. And so that's really what the heuristic was designed around. And so this is a version of what was reported to the Tasman CEOs. They had their hospital names on it. And in the time that we were doing this, and I absolutely, the groundwork for this had been led by all the leaders in the field. And I think the scorecard helped them push it over the goalposts for things like getting desflurane off the formulary, because by the time between when that started and we finalized, we ended up with 5 of the 13 OR systems with it off formulary. And so I can assure you that there were some panicked emails with CEOs a couple of days before this was presented to update it, because they were seeing their hospitals looking not so good, and they wanted to make sure that we did get the information that we needed to rank them accordingly. So I think it was a fairly effective strategy from that perspective. And then each hospital got their own personalized version of this scorecard. So both where they are and what we understand to have been going on to provide the rationale for that, and then what they could do differently. And of course, I've anonymized it, but this is a fairly a 3-page going through these 10 items. And then we have since then, thanks to Nava Khan, made this fillable version, which is on our website. And I think this is quite usable, and folks can go through these 10 items and see what it takes to achieve the green score or the amber score. And this will be revised. This will be improved. New things already. Ali Abbas has reached out to me and said, when are we going to update this? When are we going to push the envelope farther? When are we going to have different items on this scorecard that we didn't have before? And when are we going to change our heuristic around what it takes to be green? So as I say, a very, very adaptable. And further to that, our scorecard's not unique. We drew on, and I think reflect existing evidence and other scorecards and guidance that exists. And what's important about this kind of work, as I say, is working with the community and being reflecting the evidence, reflecting the science, but also working in close collaboration with the community. So I think the scorecard and benchmarking was really effective in fostering action because of the leadership that already existed from clinicians and staff in the field, because we were able to corral significant executive and CEO engagement, because we identified ambitious but achievable change, and because we engaged in a collaborative benchmarking exercise. I think it's insufficient, of course, to do this change in a bigger and more consistent way to keep this moving forward. So very much with Dave Smith's advice and guidance and others who are helping to lead this work, The need for more detailed how-to guides, who did what where, how did they measure it, what issues did they face, and really using QI methodology to detail those root causes, those clear problem statements, and so on. I think that the frontline leaders who are in their settings going to do this work in a sense, or hopefully not too much work, but really motivate the change in their context. They need support to do the work. Train the trainer, I think, is a good way to think about this. And again, as I say, QI methodology and infrastructure, which the NISQIP program has, and I'm a big believer in collaborative action. So